Hello, everybody. Welcome to a new episode of Shades of Radiology. Today, we'll be talking about ovarian torsion, which is considered an imaging enigma. Ovary has a dual blood supply. It is supplied by the uterine arteries and the ovarian artery. The pathology that is seen in ovarian torsion is most often it starts with the presence of a lead point, which most often is a benign ovarian lesion. And when this torsion occurs, what really happens is that the suspensory ligament of the ovary twists. Because of this twisting, this leads to a compression of the ovarian vein and lymphatics, which in effect leads to a massive enlargement of the ovary and the vascular pedicle. At this moment, there is or there might be some compromise in the venous blood flow and compromise of the lymphatics. However, the arterial flow remains patent. Because of this, we might see an engorged vascular pedicle and a vascular ovary. However, the ovaries are salvageable, and this is a reversible pathology at this moment. Further from this, if there is no intervention that happens at this point, further from this, the arterial supply gets compensated. Once this happens, the ovary undergoes ischemia and hemorrhagic infarction. Following this, the ovaries are not salvageable. The same thing when it is put in a radiological or imaging perspective, what we see is there might be a normal sized ovary or a normal ovary without any pathology, secondary pathology. Further, it undergoes torsion, which leads to an asymmetric ovarian enlargement when we compare it to the opposite side. The ovary, when it enlarges, it might be having a primary pathology within it, and also there might be secondary engorgement which leads to the enlargement. Because of this, when the ovary enlarges, it tends to spill over from the adnexa and moves towards the midline. This movement towards the midline occurs because of the size of the ovary and also because of the torsion or twisting of the pedicle. The abnormal size or the position of the ovary should be a pointer to the possibility of an underlying ovarian torsion. As the ovary moves towards the midline, either anterior or posterior to the uterus tends to get diverted or deviated towards the side which is affected, that is, towards the side of the torsion. The pedicle at this moment would be found to be thickened and engorged, and because of the resultant ovarian edema, the ovary is seen to be big, enlarged, with increased central medulla of the ovary. The follicles are found to be arranged in the periphery in a string of pearls fashion. This further continues to develop a hemorrhage or a hemorrhagic infarction. So, the basic risk factors that we see for ovarian torsion to occur is the presence of a benign ovarian lesion. Surprisingly, the protective action for the occurrence of an ovarian torsion is found to be when there's a presence of adhesions, which might be secondary to malignancy, endometriosis, PID, etc. So, as had been mentioned before, imaging wise, the findings that we see or encounter are massive edematous ovary, an ovary which has migrated to the midline, uterus which has been pulled towards the side of the torsed ovary, peripherally placed ovarian follicle with an edematous central stroma, inflammatory change in the adnexa, hemorrhage is the final stages is hemorrhage and infarction, which might be evidenced as absent flow within the ovaries. So, first modality that we come across is ultrasound. So, what we see in ultrasound, the first pointing thing that should be getting our attention is the fact that the ovary would be displaced from the adnexa and would be lying in the midline, mostly anterior or posterior to the uterus. If we are able to demonstrate the whirling of the pedicle, it is considered highly specific for the presence of an ovarian torsion. The earlier mentioned finding of ovarian edema is very well appreciated. It can be seen as an ovarian enlargement, and the central part of the ovary appears to be echogenic, and the follicles tend to get pushed towards the periphery in a string of pearls manner. The ovarian torsion, oftentimes people look out for the presence of vascularity. However, this is not a reliable sign because in the initial phases, it is only the venous flow which gets compensated. Even at times, the venous flow may also be patent. So, if there is any in the initial phases, we might see there's a high resistance flow in the arterial system, but there might be variability in the arterial flow pattern as encountered with the menstrual cycle various phases. So, if we see any abnormality in the flow pattern and if it is a positive point, then it is highly specific for the presence of an ovarian torsion. However, if we do see a normal flow and we see a normal resistance, that does not rule out the presence of an ovarian torsion if we are thinking in the right clinical context. The patients normally do not come for a CT, but at times the patients present with a non-specific abdominal pain and ovarian torsion does not get detected or suspected. So in such cases, the patients end up undergoing a CT scan for evaluation of the abdominal pain. Again, as has been mentioned earlier, the basic pathology remains the same. So we look out for the same findings. So first is the ovarian position. As can be seen here, the ovary is seen in the midline. It is seen to be lying anterior to the uterus. We can identify the uterus in this cut with the presence of an IUCD within the canal. So the ovary is seen in the midline anterior to the uterus. This is another non-contrast CT which shows that the ovary is hyperdense, which can be seen in the first image also. So this hyperdensity, the intrinsic presence of this intrinsic hyperdensity in the ovary suggests that there is a secondary hemorrhage that has set in within the ovary. You can also see some presence of fluid in the pelvis. The triangular thing that has been marked on the left hand side of the uterus, or the presence of some soft tissue in the left hand side, is suggesting the presence of soft tissue, which is actually assumed that this is the triangular mass of soft tissue. It is considered to be relatively reliable sign, and we often mistake it for the presence of inflammation, but this is actually the presence of engorged vessels in the pedicle. It's the engorged vessels and the tube which gives this appearance of a triangular mass of soft tissue adjacent the torsed ovary or the torsed adnexa. MRI is a problem solving tool. When we do not find an answer with the ultrasound or we are still in doubt, we can take it to MRI, which is highly specific in detecting the presence of torsion and also the presence of a lead point. As can be seen in this case, we can see that there is a cystic lesion in the ovary which is having some layering. It is a hemorrhagic cyst or a cyst which has undergone a secondary hemorrhage. We can also see that the ovary is enlarged. There's ovarian edema, central stroma is edematous, and the ovary is sitting posterior to the uterus. The position of the ovary has changed. The ovary is enlarged in size as compared to the opposite ovary. There is ovarian edema. The follicles have been pushed to the periphery of the ovary, and we are also able to identify the lead point. If we are able to demonstrate the whirling, which should be looked out for in the various sections, the sag, axial, coronal, we should look out for the presence of whirling and try to demonstrate it. The presence of whirling is considered to be highly specific for the diagnosis of an ovarian torsion or an adnexal torsion. Here we can see that there is T1 intrinsic T1 hyperintensity in a non-contrast study, which is on the left hand side. This is suggestive of the presence of hemorrhage. And on the fat suppressed image on the right hand side, we can see in the subtracted images that there is no enhancement, suggesting that there is a hemorrhagic infarction which is set in, and already this is not a salvageable ovary anymore. This is the same finding that we had seen in the CT earlier. The engorged pedicle or the engorged adnexa tends to have this triangular mass of soft tissue. It is seen in the region of the adnexa which is involved, and we should look out for this finding. It often gets mistaken for the presence of inflammation, but this is actually the engorged soft tissue or the engorged adnexa. So the importance of ovarian tissue torsion is that it is an acute emergency. It can lead to infarction. However, This is a salvageable pathology, and so it is imperative that we have a high index of clinical suspicion and look out for the findings, because till one point this is a salvageable pathology. The typical findings that can be seen across all the modalities are enlarged abnormally positioned ovary relative to the opposite ovary, or relative to the uterus. It tends to come towards the midline, mostly lying anterior or posterior to the uterus. The uterus tends to move to the side of the torsion. Classically, the ovary gets engorged, tends to have ovarian edema, with the follicles ending up seen in the periphery of the enlarged ovary. In cross-sectional imaging, we should look out for the evidence of triangular adnexal soft tissue, which is the engorged pedicle, and also look out for the evidence of hemorrhagic infarction. This is a very good read, and most of the images have been taken from this article. This is one of the latest journals now in the radiographics. And for all those who are interested in knowing more, they should read this article. Thank you. Hope this was useful to you.